Okay, so today I'm going to try and answer the question, is fasting good when one is at risk of liver cancer? The short answer would be yes, but we need to firstly define who are the patients that would mostly benefit out of it. First of all, what is intermittent fasting? Well, intermittent fasting encompasses various eating patterns, and it's characterized by these alternating periods of eating with periods of fasting. The periods of fasting ranging for 12 to 24 hours a day, 2 to 7 days a week. The most famous types of intermittent fasting are alternate day fasting, which means that you fast for 24 hours every other day. The second type is a 5-2 diet, meaning that you fast 24 hours in 2 non-consecutive days a week. And the third type is time-restricted eating, meaning that you restrict your eating period for 8 hours a day. A fourth type, and maybe the most historical one and with religious roots, is Ramadan fasting, which consists in fasting from sunrise to sunset, and depending on the geographical area you live in, you'll end up fasting for 12 to 18 hours a day. The cardiometabolic advantages of intermittent fasting are due to a reduction in energy intake with the maintenance of the quality of the diet, which will result in a decreased body weight that ranges from 3 to 8%, with more important results in the alternate day fasting group. Moreover, there is a decrease in an improvement, in body composition with reduced cutaneous fat mass and lean mass, a decrease in inflammatory markers, in oxidative stress markers, and a reduction in cardiovascular risk factors, namely blood pressure, cholesterol, and triglyceride levels, and also an improvement in glucoregulatory function, most importantly, a reduction in insulin resistance. Looking at the molecular mechanism behind intermittent fasting, we can see that there is this switch from glucose to lipid metabolism in order to maintain the energy homeostasis. As the level of glucose decreases, there is an increase in glucagon, which favors glycogenolysis and gluconeogenesis in order to support the glucose level. But depending on the glycogen level within the liver at the beginning of fasting, after 12 to 36 hours, it was observed that there is this switch for the preferential use of lipid-derived ketone bodies instead of glucose. With prolonged fasting, there is an increase in glucocorticoid level, increased white adipose tissue lipolysis, which increase the level of free fatty acids. These free fatty acids are uptaken by hepatocyte, increasing PPAR alpha, regulation the function of PPAR alpha, which favors beta oxidation and the production of ketone bodies. Moreover, during fasting, there are two nutrient sensing pathways that are regulated, meaning AMPK and sirtuin-1, both of which have an inhibitory effect on NFKB, which means that decreases inflammation. Moreover, these two pathways also increase autophagy, and during fasting, there is also an increase in adiponectin and a decrease in leptin level, which will both result in a decrease of inflammation and in insulin resistance. But who are the patients at risk of liver cancer? Well, most of these patients develop HCC on the background of liver cirrhosis. So therefore, these are the patients at risk. And the second category I'll talk today is NASH patients that can develop HCC even in a non-cirrhotic state. But applying a restrictive dietary intervention to a group of patients that are at risk of malnutrition and sarcopenia would somehow lead to deleterious effects that could not outweigh the beneficial effect of fasting. 20% of cirrhotic patients in the compensated state and 50% of cirrhotic patients in the compensated state suffer from malnutrition due to poor oral intake, malabsorption, and maldigestion. Moreover, as 30 to 70% of them suffer from sarcopenia, these two conditions can increase the compensation of liver disease, reducing the overall survival and increasing the morbidity and mortality in patients that undergo liver transplantation or hepatocellular carcinoma treatment. But this malnutrition in cirrhotic patients was shown to be secondary to an accelerated state of starvation that is characterized by an early shift from glucose to lipid metabolism in the early post-obstructive state. Moreover, this accelerated state of starvation is further accentuated by decreased glycogen storage, which characterizes cirrhotic patients. Moreover, it was shown that during a night fast, 70% of the energy in a cirrhotic would come from lipid metabolism, which is reflected by this increased resting energy expenditure normalized to muscle area, as it was shown in this study, to an increase in the level of ketone bodies and decreased respiratory quotation. Moreover, cirrhotic patients can also have a dysfunction of glucose metabolism in terms of insulin resistance, glucose intolerance, and some of them even have diabetes mellitus. Because of these potential deleterious effects of fasting, I couldn't identify any prospective clinical trial that assessed the most famous types of fasting in cirrhotics. But because this Ramadan fasting has this religious background, I could identify 4 observational studies that somehow have divergent results. But to sum up, they concluded that a cirrhotic patient with CHALPAG-A can benefit from Ramadan fasting through a decrease in BMI, in serum glucose, and improved liver function with no decompensating events. Moreover, cirrhotics with CHALPAG-C have an increased risk of decompensation, a decreased level of bilirubin and creatinine, and decreased level of albumin. As all these authors concluded, fasting is not recommended in patients with CHALPAG-C and most probably also not in patients with CHALPAG-B, but there is this window of opportunity for cirrhotic patients with CHALPAG-A. And I think out of these, those that would mostly benefit are those with obesity and cirrhosis. Aligning to the global pandemic of obesity, it was shown that 33% of patients undergoing liver transplantation in the United States, they also present obesity. The presence of obesity increases the risk of HCC development by 2-fold, by 4-fold increases the risk of mortality, and by 2-fold increase the risk of life-threatening complications. The group of Professor Bezigote actually showed that in accordance to the BMI level, over time there is an increased probability of a forced clinical decompensation of cirrhosis, with the highest risk being in patients that are obese. Moreover, it was also shown that an increased BMI increases also the risk of developing HCC. But the same group of Professor Bezigote showed that applying an intensive lifestyle intervention, in this case consisting of a hypocaloric diet with physical activity and under close nutritional surveillance, would lead to a decrease in HbPG value and a decrease in portal hypertension and portal hypertension complications. But in this study, it wasn't shown that there is a decrease in portal hypertension in accordance to the percentage of weight loss. But an interesting fact was that patients that lost more than 10% of their body weight had the final HbPG value below 10 millimeters of mercury. Although this study I'm presenting here was not performed in cirrhotic patients, what I wanted to stress out is that combining an intermittent fasting protocol with a protein pacing protocol, meaning 33% of energy coming from proteins, would finally lead in this study to an increased free fat mass per body weight, therefore an increased muscular mass. Therefore, we can summarize somehow that in very selected cirrhotic patients with CHALPAG-A, without sarcopenia, malnutrition, and with obesity, we can apply an intermittent fasting protocol, which is paced with protein protocol, and also maybe some resistive training in order to improve their outcome. The second category of patients that can benefit from fasting are NASH patients, because in these patients they can develop HCC even in a non-cirrhotic state. The risk of HCC in NASH patients come from these metabolic stressors that induces an increased reactive oxygen species level, ER stress, oxidative stress, and hepatic metabolic reprogramming, which favors hepatocyte death and a chronic inflammation within the liver. These two together, in accordance also to dysfunctional immune surveillance, leads to an early HCC development in these patients. But as I showed the beginning with the cardiometabolic advantages and molecular mechanisms behind intermittent fasting, we can say that intermittent fasting can act on the main pathogenic chains of NASH, meaning referring to insulin resistance, autophagy, lipophagy, and inflammation, and can hold promise that it can reduce or even stop the progression of the disease, and so reduce the risk of HCC development. With this study, I wanted to put some perspective in the place of intermittent fasting in NASH patients, because what it actually showed is that comparing a group of NAFLD patients with diabetes that underwent liraglutide treatment versus a group of patients that underwent a 5-2 diet for 24 weeks, there couldn't be identified almost any differences in the results in terms of body weight, in terms of cholesterol metabolism, in terms of oxidative stress level, increase in antioxidants level, or decrease in liver fat content. The only advantage of liraglutide was the fact that it controls better glucose metabolism. Otherwise, they had similar results. In the short time I have left, I want to outline the possible advantages of fasting in cancers. And Nesioni and his group tried to summarize a little bit the potential advantages, and they showed that there is a decrease in tumor growth promoting factors such as insulin growth factor and insulin receptors. Moreover, fasting also has this anti-Warburg effect with the decrease in glucose uptake through downregulation in glucose receptors, a decrease in aerobic glycolysis, which forces the cancer cells to undergo oxidative phosphorylation and making them more susceptible to chemotherapy action and increasing cell death. Also, an interesting fact that was observed between normal cells and cancer cells is that they respond differently to restrictive diets and to the absence of nutrients in their media. While healthy cells tend to enter this maintenance mode that is characterized by the increased catabolic processes, increased repairing processes in order to maintain the stability of their genome and proteome at the expense of growing and of multiplication. Cancer cells are not able to enter this maintenance mode, and that is because they have this uncontrolled activation of growth through mutagen mutations, and also they lack the antiproliferative signals due to mutation in tumor suppressor genes. Therefore, this makes them more susceptible to the effect of chemotherapy and to radiotherapy. And because I couldn't actually identify any clinical trial assessing fasting in HCC, well, what I did find were some preclinical studies that showed this differential stress sensitization in HCC cells. And the first one showed that although fasting media and sorafenib can both reduce the cell proliferations, it was the combined treatment of fasting and sorafenib that had the best effect in reducing this HCC cell proliferation at 72 hours from the beginning of treatment. And moreover, another study showed that HCC cells that present P53 that are P53 positive have a decrease in the tumor burden if they are exposed to a combination of sorafenib plus fasting. So is fasting good when one is at risk of liver cancer? I can say yes, especially for NASH patients, and maybe to a very selected population of cirrhotics that have the previous mentioned characteristics. Thank you.
Thank you, Iulia. It was very clear, and you cover the mechanistic aspects also of fasting. Professor Ramadori.
Thank you. Thank you. Thank you. Very nice talk. Thanks a lot. I found interesting the study on Ramadan. So there was a study where it was found that decompensation during Ramadan and after Ramadan increases.
Yeah.
What is your guess? Why is that?
Why it increases? Well, I think in that study where the compensation increased were a mix of patients that have both child I and child C. It was a combination of classes of cirrhosis, and I guess those that were in more advanced stages were able to progress and didn't have any further benefit. And I think they through fasting they would end up in the starvation mode more frequently if they have this lack of glycogen in more advanced stages than in earlier stages. So I guess there is this point of no return where you, when applying a fasting, would end up being deleterious to these patients.
But decompensation, I imagine you mean ascites formation, let's say, because they would not probably get encephalopathy, but they would get ascites.
Yeah.
So I don't know. I didn't know the paper, so I think they may have the hypoproteinemia would worsen. What we can worse and they would develop ascites because of hypoproteinemia. Maybe. I mean, this is just a you can go through the papers and check it, but this is my guess.
Okay, thank you.
Yeah, no, I agree. Albumin, I don't know if they measured it, but that would be interesting. Dr. Zhang, you had your hand on before. You have a question?
I don't.
Oh, okay. Sorry.
It's a great presentation. Yeah.
So Iulia, during chemotherapy, so would you advise fasting to patients who have HCC and you treat them and based, kinase inhibitor or immuno-oncology, you will tell them if they are not child C, obviously they will be not treated for the HCC. So you can advise them to fast?
I think it depends on the liver function at that moment. Probably there would be this chance for some of the patients. It was shown in the other type of cancer that intermittent fasting during treatment would increase the adverse events rate, and but there wasn't any study that would actually show an advantage in the response to treatment or in survival. So at this point, I think it's a little bit premature to say that.
You talk hepatocellular carcinoma here, right?
No, other type of cancer. It was studied applying intermittent fasting in other sort of cancers, mostly breast cancer. I find some articles, but for ACC I couldn't find any article in this sense.
But look, in breast cancer, the data support fasting. If you look at the publication from Longo, from the group of Longo, they say that they tolerate better chemotherapy and you can give the full chemotherapy easier in patients, women with breast cancer who are fasting. And there is less side effect of the drugs, and that they also have mice data. So I think that should be considered also in HCC. I mean, it's maybe just one group of investigators, but Longo is the last author. And I think that's interesting to consider also. Yeah. Oh, I see Dr. Zhang, who has a hand on.
Hello.
Here.
Thank you for the great presentation. I have a question. So you mentioned there are different patterns of fasting, like 5-2 Ramadan, or also like eating during the day and fasting longer hours at night. Would you suspect like there are similar effects with different patterns of fasting regarding to the risk of liver diseases?
Sorry, can you repeat the question? If they are similar?
Yeah. Do you suspect they are similar, or there would be differences regarding the outcome?
I think the outcome would be different in terms of the better results. I think they're going to be within alternative fasting and 5-2 diet, because they lead to a more important decrease in body weight and increase in glucose levels, and they had better results from this perspective. But time-restricted feeding, I think it's in a type of diet that is a good compromise, because it's also easier to adhere to than alternative fasting. So I think from the perspective of adherence would be better to apply a time restricted feeding, but otherwise the results would be better with the other two.
Thank you.
Thank you very much, Iulia. Thank you for this very nice presentation and for the discussion.